Perfect. Perfect. Well, I'm Dr. Paulette Bryant, and I work at the Hemophilia Treatment Center, one of them in Charlotte, North Carolina. And we do peds, but Atrium does pediatrics and adults. But I think we'll be a lifespan fairly soon. We have some great hematologists in our system. The objectives for the talks today, I'm going to do a broad paintbrush of rare bleeding disorders, and then I wanted to give you case-based scenarios, because I can tell you and go womp for an hour, but once you see the cases, you'll realize how rare these are and how difficult they are to diagnose, and how important the patient is in giving the history and making the diagnosis. We have to listen to the patient. And lastly, I wanted to go over, how do you live with a rare bleeding disorder? It's rarer than hemophilia A and B, but how do you manage that? And how do you talk to other people about it? So everyone is somewhat familiar on this call on how to make a clot. You get cut, the blood cells go, the platelets come in, and then they make this fibrin network. And that's like the gum in the dam that keeps the blood going, and the clot works perfectly. And there's several components to making that clot. The platelets, which are these small little plate-like cells that float around in the blood. The vascular system, which is what lines the blood vessels, and then the coagulation proteins. And all of these interact. So when we talk about rare bleeding disorders, we got to talk about the platelets, the vascular system, and the clotting. And so there are rare bleeding disorders that involve the platelets, like Glanzmann's thrombocythemia, and that's like 1 in a million. Now, having said that, if you have Glanzmann's, you're 1 in a million people. We have 3 active patients at our center that has Glanzmann's. Bernard Cillier, I looked for incidence, it's unknown, and platelet storage pool disease. That's when the platelets, the granules that spit out all those information and factors that help make that fibrin, that's also unknown, but it's estimated to be well above 1 in a million. And then there's a new rare bleeding disorder called BUC, bleeding of unknown cause. And that, in a nutshell, is we don't know what you have, but you're bleeding. And we think it's platelets, or we think it's vasculature. And you may say, well, that's like a silly title. But the truth of the matter is that a lot of people with bleeding disorders, sometimes up to 30% in some studies, we don't have a diagnosis for you. You're bleeding, but every test comes back abnormal. And we cannot ignore you because you are bleeding, in spite of what our tests say. So at some point, we're going to develop a test that will pick up what you have. But at this point, we're at an unknown cause. And hopefully with genetic testing coming into, we'll be able to figure out what you have. The other thing I told you about was the vascular system. You can have a vascular abnormality, a connective tissue abnormality. And I have a picture below of loose joints with a thumb and very hyper flexibility. And those people are 1 in 5,000. But you can have bleeding if you have a connective tissue disorder. Another disorder called hereditary hemorrhagic telangiectasia, or Oslo-Weber-Rendu, is 1 in 8,000. And then those are just clusters of blood vessels that bleed. And they can be in your nose, your mouth. And then rare connective tissue disorders, even scurvy. You know, the folks that came over on the Mayflower that didn't have lemon and lime, they can bleed. So this is all related. So let me put it into perspective. If you have hemophilia A, you're 1 in 5,000. If you have hemophilia B, you're 1 in 30,000. If you have von Willebrand's disease, about 1 in 100. But we're talking about something that's super rare. So, but it's called rare bleeding disorders, but it should be super rare bleeding disorders. And I won't be able to cover everything, but great websites are the National Hemophilia Foundation, the World Federation of Hemophilia, and then the European Network of Rare Bleeding Disorders. So when we make a clot, you know, you have the vessel, you have the platelets, and then you have the clotting factor. And a lot of people have seen this diagram. The clotting factors, one hits the other, and then it stops over the bleeding, and that's normal. In hemophilia, you're missing 8 or 9, all right? And so you don't get that, you don't have that coverage over the bleeding. However, in rare bleeding disorders, all these other guys, those are the guys that you're deficient or you're missing. And the other way we looked at it, back in the day when I was training as a hematologist, you had all the numbers of the factors and they were all lined up. And at the end, this fibrinogen was part of the how to make a clot, that fibrin strand. The PT measured factor VII and all the combined bleeding factors. The PTT measured 8, 9, 11, and all the combined. And I'll make you a hematologist now, maybe not board certified, but at least you could play one on TV, okay? So if the PT is prolonged and the PTT is normal, then the only thing that could be wrong is factor VII. And if the PTT is prolonged, but the PT is normal, the only thing that could be wrong are those 8, 9, 11. If both are prolonged, it's the combined pathway, and there's certain factors you cannot measure with this. And we're going to go over that today. So if you have a rare bleeding disorder, you truly are 1 in a million. If you're deficient in factor VII, the one on the side, it's 1 in 500,000. Factor 10, 1 in a million. Factor 11, 1 in a million. Factor 13, 1 in 2 to 3 million. They say that they're vaccinating 3 million people a day. That would be 1 out of that 3 million. And on this slide, I just give you an idea. The PT and PTT are normal. When you come in and you're bleeding, the doctors, at least the ones on TV, should be saying, let's get a PT and PTT. If the PT is abnormal, it would be a factor VII. If they're both abnormal, 10. And then look on factor 13, which is really rare. They're both normal. So
Dr. Bryant, remind us what PTT, prothrombin time, and what's...
Okay. And this is partial thromboblastic time. And this is prothrombin time. And essentially what we're measuring in the prothrombin is factor VII, and the partial thromboblastic time, we're measuring these other factors, 8, 9, 11. So if you have a hemophilia B or A, this time would be abnormal for you.
It's the time it takes you to form a clot.
Right, it's the time it takes you to form a clot, and it's prolonged if you're missing one of those factors, similar to this diagram. Okay, so it'll take a long time to make this clot. All right. So when we're talking about rare bleeding disorders, we're talking about everything but factor 8 or 9 deficiency. All right. And factor 8 and 9 are rare. So we're talking about the super rarefied air if you have those. It is about, if of all the people with bleeding disorders, rare bleeding disorders make up 3 to 5%. All right, so we're talking super rare. And of all of those who have rare bleeding disorders, factor 7 and factor 11 are the most common. They have highly variable symptoms. They can be either severe or very mild. You can have a few bruises, or you could bleed as if you had hemophilia. And some are worse than having hemophilia because you can clot and bleed. Most of them are from are autosomal recessive. And let me go through that. Let's go back to if you have factor 8 or factor 9. Your mom was generally a carrier. Your dad wasn't. And when you had children, the mom gave her X to a male child to get hemophilia A or B. And I wanted to do this next one because I can't tell you how many young men I show this to, and they come back and they say, I'm having a baby. My son's going to have hemophilia. And I'm like, no, you're good. You can't. So this is for just a reminder that if you have hemophilia and you're a man, you can only give it to your daughters as carriers. If you have a son, you can't give an X to your son, your wife does. So you should be in good shape. But these rare bleeding disorders, they don't follow the rules. They didn't read the book. Either one parent has the gene and has a 50% chance of giving it to her children, or the father could have it. And most of them are autosomal recessive. The man and the female have one copy of the gene. They have no clue they have it until they have a child that they give the affected gene to that child, both parents, and then that child has it. So with hemophilia, a lot of times we say, are any free bleeders in the family, da, 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 and someone will say, yeah, or there were really heavy periods of blah, blah, blah. And these rare disorders, most of the time the parents have no clue. And that really gives a different flavor and the diagnosis and living with this disease. So what are the symptoms? If you have one copy, you usually don't have any bleeding. It's usually mucous membrane bleeding, or you go to surgery. You know, you've been fine all your life. You go to surgery for appendix or a knee bleed or a knee issue, and then you bleed after surgery, and everybody's like, well, you told us you didn't bleed. What happened? Also, you can have trauma. When I was in the military, we had one man who was a chief of a submarine, and he fell, hit his knee, and kept bleeding, and he had a rare bleeding disorder. You can have heavy periods, and the other thing that goes with this is spontaneous abortions. So you're thinking, but a lot of disorders have trouble getting pregnant. And if you have a severe form of this, you can have a bleed in your brain, or parent will say, well, his umbilical cord bled for the first month of his life or the first 2 weeks of his life. And so these are symptoms that are not usual. And most parents, if they aren't aware that this is a symptom, they don't talk about it. So how do we make the diagnosis? The biggest thing is family history. So when you come, we ask a lot of questions, and a lot of people say, well, why do you do that? Because that's one way of trying to figure out what you have. Any history of problems with childbirth, anybody need a blood transfusion, any bleeding in your umbilical cord or your joints, or any bleeding in the brain. And are there tools to assess this? There's the PT, the prothrombin time, and the prothrombin blastic time as labs, but we have a short form called the brief assessment tool to look for bleeding. We're going to ask you about tooth extractions, nosebleeds, bruises. And then if you're having heavy periods, we have the pictorial bleeding assessment tool. And as anybody, all women out there with heavy periods, I need you to have the Sisterhood app. This is what it looks like. And what it does is, if you're having flooding in your periods, you can just click how many a day. You can even put symptoms. But what I look at is this number up here is the pictorial bleeding assessment score. The app automatically does it. Any score over 100 means that you have abnormal bleeding. Okay, so if you have a rare bleeding disorder, it won't be like I do a factor 8 and 9 and say, oh, you have hemophilia. This is detective work where the patient has to be involved as far as how heavy the bleeding is, what happened with grandma, what happened with other people, and what happened to the patient. So the challenges are, rare bleeding disorders are super rare. What are the challenges in making the diagnosis? Well, mostly what we have is that PT or PTT. And those tests are not very sensitive. So you might miss it. You may have a low factor 11, but a normal test, and then we miss you. And then treatment guidance. In hemophilia, remember, if your factor level is less than 1%, we go, you have severe hemophilia. You could have a level of 2 or 3% and not bleed, or conversely, a level of 4 to 5% and bleed significantly. So we can't give you that follow-up of what's good, what's not good. And then there's no correlation to the severity. If you have factor 7, I had a young lady who was a cheerleader, and her level was like 5-10%, but she had such significant bleeding. It was very, very sad. And then expertise, because they're rare. I told you platelet Glanzmann's is 1 in a million, but I have 3 patients that I'm following right now. Most hematologists may not have that frequency of patients, so it's kind of rare. So the best way to explain this is to have patience, because once you have a patient, you'll say, oh, that could be me, or I know someone like that. And I'm going to start out with probably one of the more common rare bleeding disorders, the case of a toddler with a broken leg. So she came into our emergency. She was 2. She was cute. She had fallen. She had broken her leg, and we presume that because she cried when you tried to stand on it. And we did an X-ray, and she did have a broken leg. So we did that PT and PTT test. The PT was abnormal. So that meant the only thing it could be was factor 7. And she read the book. Her factor level was 4%, and it should have been 50%. So we had factor 7 product there, Novo 7. It's made by Novo Nordisk. And we were able to give that to her every 4 to 6 hours and then twice a day. She was great. She went home, and we didn't put her on preventive treatment. Well, by the time she got 7, she went out of state, came back to us. She had target joints when she returned. And target joints are when you bleed into your joint and the blood stays there and you get a lot of scarring and it's very painful and you have more bleeding. So you have a 7-year-old with target joints with factor 7 deficiency, all right? And so she had to go and have the target joint surgically repaired, all the scar tissue cleaned out. And at 9, she had her right, and on 7, she had her left. We even had to place a port so that she could give factor before she had increased activities. So this is a rare bleeding disorder, 1 in 500,000. She came into the exam room for a broken leg. And now she has trouble with walking, and she has a central line. And that's what makes these rare bleeding disorders incredibly impactful and life-changing for all those patients who have them. So you might say, well, why didn't her parents know that? Again, it's autosomal recessive. Each parent had a gene. They had no clue. This factor 7 usually presents with nosebleeds, gum bleeding, easy bruising. You can have a bleed in your head when you're delivered as a baby. You can have blood in your gut. You can also get a clot from us treating your factor 7. There are treatments for it. There's a concentrate, there's a recombinant, there is a product we call prothrombin complex, which is a mixture of factors. And it can be lethal to asymptomatic. And some patients with low factor 7 don't bleed at all. So it's very hard to figure out, are you going to bleed or not? Some patients have to be on prophylaxis, but the factor 7 only lasts for 2 hours in the body. So the patients that I have on that, a lot of times they're on twice a day, but we think it's better, but we're not sure. And the last point is, if for factor 7 patients who are deficient, when they get old enough to have babies, if their factor 7 is less than 15, they have a high risk for postpartum hemorrhage. So let's say their factor VII is 8 or 9, they don't have any bleeding. When they start having babies, it may become very impactful. They could have a lot of bleeding after having a baby. And so importance in making the diagnosis. The reason that our ER team even got a factor VII and the PTT was the child's bruises, not her broken leg. So if she hadn't broken her leg, it might have been a little bit longer before she came to our attention. Again, the PT or prothrombin time and factor VII was over here. And that was what was low. All right. The next patient is something a little bit different. It's the case of the infant. It's a 6-month-old male who presented with sleepiness, and they had a hard time waking this little guy up. In retrospect, the mom said that he bled from his umbilical cord for 14 days, and he was kind of irritable. She said, I don't know why he's not waking up. He didn't fall. He didn't have any head trauma. He has no fevers. We are sure he didn't somehow get into some poison or something. We don't know why. So he goes in the emergency room. We get a CT scan, and he has bleeding he has bleeding underneath his skull. And actually for him, this isn't his picture, it was on both sides. It was pretty impressive. And during the scan, he stopped waking up. So in North Carolina, when we see kids with bleeding in their skull, the first thing as a physician you want to rule out is child abuse. And unfortunately, it's a lot more common than you would think. And so that was on everyone's mind. Could it have been a poisoning? Could he have been crawling or rolled over and put something in his mouth? And the last thing on their mind was a bleeding disorder. But keep in mind, he didn't have a skull fracture. He just had bleeding. So we did our normal PTT, and that was normal. We checked the number of platelets. They were normal. We did the von Willebrand's disease panel. That was normal. They looked for skeletal fractures. They were normal. Finally, they called the hematologist. And this is the one element that is you can't check with a PTT, and his factor 13 was less than 1%. We did the special test for factor 13. We were able to give him a recombinant factor 13. Luckily, this is a once-a-month prophylaxis. It took 14 days, but his head bleed got better, and he did well. I bring this up because imagine if they hadn't called the hematologist, he would have continued to bleed and may have died from his bleed. And we're talking about 1 in 3 million people having this. This is so rare. The trough level or the lowest level you want them to be at is 5 to 30%. It's autosomal recessive. Neither parent knew they had it. Again, the umbilical cord bleeding was a little bit of a clue, but people who have it, particularly women, can have miscarriages. So they can go their whole life with no bleeding, and then they can't get pregnant. And so I always remind our GYN and OB friends that it could be factor 13. They can have joint bleeds, and they can bleed after surgery. Factor 13 is so rare because it's made in 2 different places, the bone marrow and the liver. It can be very severe. If you have bleeding from your umbilical cord, it's likely to be severe, and you can have a brain bleed. And a lot of women who have it have miscarriages. It has a long half-life, so you can give it once a month, and it'll do wonders. Factor 13 activity over 30%. Usually people are asymptomatic. And if you have it and you want to be pregnant, we really recommend taking it even if the factor 13 product, even though you may not be bleeding. There's a concentrate. It comes in a plasma, and the recombinant concentrate only covers one subtype A, one part of the factor 13. If you have the other part that's missing, that's super rare, you have to use plasma. All right, I'm coming to the end of my cases to explain how this rare bleeding goes, but I have a 14-year-old cheerleader. She came in with heavy periods, easy bruising since she's crawling. Everybody said, oh, that's just the Jones way. Everybody bruises. At one point, she had blood in her stool that resolved. She started her menstrual cycle at 12, and here she is at 14. She's tired, and she's been bleeding for 20 days. Mom has had heavy periods. She's had big clots when she has her period, and that pictorial thing I told you about, that score came up 500. Over 100 is bad. I'm telling you, you guys could all be on TV and be hematologists after this. The other thing is her iron level was low because she bled every month. Her iron was low, but her blood count was 5. Should have been 11, 12. That's very low. And we couldn't stop her period. So again, we got a PT, PTT, and both were prolonged. So it's in this combined track of clotting. And her factor 10 was low. So we got factor 10 concentrate, and we put her on a medicine called Listita. Those of you who might have von Willebrand's disease, it's tranexamic acid, and what it does is prevent the breakdown of the clot. So we're thinking factor plus that, we should be good, and we gave her some oral iron, and because she was so tired, her hemoglobin was 5, she got a blood transfusion. In spite of that, she continued to bleed on her Listita and her birth control pills. So once she went out of the hospital, she was on Listita and birth control pills. She kept bleeding, so we had to go back to giving her factor. This case is important because less than 1% really doesn't tell you what your treatment's going to do, how effective it's going to be. I mean, and for this particular girl, she had to learn how to self-infuse at 14 for her periods so that she wouldn't bleed during her periods. So, and I would submit to you from 12 to 14, she was slugging it along. She was an A student, tired, bleeding all the time, but she just made the best that she could until she got here. She is infusing, and that happiness is that she wants to be a doctor. So this got her into the medical field, but it's a hard pill to swallow when you're a teenager, you've done well, you have your period, and now all of a sudden your world falls apart. We couldn't find this in either parent. She had easy bruising, gum bleeding, blood underneath the skin. I call them hematomatoes, but they're hematomas. Less common. You can have bleeding in your brain. So she could have been born and had a brain bleed, blood in her urine. It presents at any age, but the severe is usually earlier. And people who just carry one copy of the gene can have problems with postpartum hemorrhage. The half-life is fairly long, and you can use plasma, and you can use factor 10 concentrates for treatment. We try hormonal suppression. A lot of these rare bleeding disorders you can try. I like to call it hormones, like birth control pills or intrauterine device, but sometimes they're not effective. You can give the factor for this one. Some women have had to have hysterectomies and or ablation of their uterus so they stop bleeding. Obviously, that would be someone who's already had their kids. And there's an increased risk of having a miscarriage. So it's beyond just bleeding. Last kid, and then we'll get into a little bit more discussion. It's an 8-year-old kid I saw in the military. He came in, he had appendicitis. They didn't even do bleeding studies on him. He was fine. They told him to go home in a couple of days. He was fine after his appendectomy. Life was good. But on his day of discharge, he had pain. He came back in shortly, maybe about 3 days. He had tummy pain. He had bled in his abdomen, and they rushed him back to surgery. They did history and labs, and both parents denied any issue. He'd been circumcised when he was young. They were like, we don't understand why he's bleeding. His PTT was elevated, and factor 8 and 9 were normal, but his factor 11 was 8%. So this was back in the old days. We gave him fresh frozen plasma. He got better, and we tested the parent. One parent, which was the father, was a carrier of the gene because this was autosomal dominant, but he had no idea. He never had any surgeries. So it can be this one, autosomal recessive or dominant. The factor 11 is made in liver and platelets. You usually don't find out till after you have surgery. People can have heavy periods, but usually there's no problem with pregnancy. And there's no clear-cut relationship for the amount of factor you have and how well you do with bleeding. The amount of bleeding is not usually related to the factor number, but where you're bleeding. Is it in your urinary tract, your oral cavity, your GI tract? It can happen after you have tonsillectomy. You can have mild symptoms and not need any treatment. And the most common presentation is someone had surgery and they bled after it. The converse, because there's a lot of people with factor 11 living in Iran, is that you can have a heart attack, venous thrombosis. If you overtreat, or even sometimes you don't give them any treatment, they can also have severe clots. Most of the time you treat with Amicar or tranexamic acid. There are factor 11 concentrates, there's plasma. Some people have tried factor 7. And this, as in all of these rare bleeding disorders, you can develop inhibitors. So what we give you, you can develop an antibody to. You can become allergic to it, and then there's always the risk of clotting. So what's the conclusion? What am I trying to get here? There are different rare bleeding disorders, and they have different presentations. And it can be the platelets, it can be your vessels, or it can be your clotting factors. And treatment is different. It can be plasma to something that we have prepared, a recombinant product, to a plasma product, to using tranexamic acid. You have to get a careful history to make the diagnosis. The history is also very laborious, but you got to do it. And making the diagnosis is critical. If the little boy who had the brain bleed, we had missed it, he probably wouldn't be here. And the other thing is, a lot of these parents are accused of child abuse, and they are not, because it's so rare. So I always tell physicians just to keep that in mind. But, 99.9% that might have been a correct scenario, but not all the time. And making a diagnosis is critical for quality of life. Look at my up-and-coming doctor with the heavy period. She's able to give herself factor so she can do what she wants to do. If we had missed it, she would continue to bleed, low factor, low iron. So it's critical in going the extra mile and making the diagnosis. And it's critical for parents and consumers for if you don't have an answer, to keep going until we can say, we've looked at all of these. You might have bleeding of unclear circumstance, BUC. We don't know why you're bleeding, but at least it is identified. So if you have surgery or something else, we can be there to support you. So why is it such a problem having rare bleeding disorder? Nobody's talked or seen the disease. If you imagine 1 in 3 million, that's a really rare disease. Some of it has bleeding and clotting. It affects boys and girls. I can't tell you how many doctors have said, girls can't have hemophilia. This is impossible. But they're bleeding. So you have to find, and some cases you end up with a central line, either in the youngster or when you're older. It can impact your ability to have children. So let's say you're not bleeding significantly, but you're a lady and you want to have a child, it could interrupt that. You can have very heavy periods. Some are associated with heart issues, and surgery can be tricky. So we call zebras kind of rare. I put that up there to remind us. I wanted to give you a resource that is just come out called Super 7. It's a story for people with rare bleeding disorders. And it's about this young guy here, and he's number 7 on the basketball team. And I put the link underneath so you could order it. It's a really good story. And it comes with a guide for parents and caregivers to ask questions. Because if you have a rare bleeding disorder, it's like, oh, you have a what, or factor 13, I've never heard of that, or are you for real? I mean, are you making this up? You look fine, kind of thing. And people with rare bleeding disorders, which is highlighted in this book, have difficulty of telling friends and family what they have, because sometimes kids can tease. Sometimes they feel lonely and isolated because they don't have 8 or 9, but there's nobody that's there that has what they have, whether it's platelet or factor deficiency. And sometimes they're embarrassed in having frequent bleeds. As you could tell, and most of these nosebleeds are very common, and a lot of these kids have to be excused from class for nosebleeds. Then there's the disappointment. You can't go on the skating trip. You can't play basketball. You can't do these. These are things that are restrictions until we can figure out a way to support you in your lifestyle choice. And then a lot of times well-meaning friends, you know how guys tussle, girls are playing, they want to do this, may cause a bleed unknowingly because they're not aware that the child or you have the bleeding disorder. So what can we do? This book is really a great book. It's very short, about talking about making a safe space about disease and feeling. And I've read the book a couple of times. I really enjoyed it. But it talks about, even if you have factor 8 or 9, which is more common, a lot of times your challenges are a little bit different than somebody else. And it's important to be able to discuss what's on your mind and not be overlooked or ignored. And then the other thing is, how do you tell your friends, your teachers, and your coworkers? A lot of times we do role playing, you know, how to do that. We also look at employment. I had another young guy who didn't want anyone to know that he had a bleeding disorder, so he didn't tell his employer so he could get the job. And then he had a bleed and he was out and he almost got fired. And so we have to go through these discussions so we can protect the patient and they can feel healthy and good about their work choices. They have to understand what they can participate in or not. Pro football is probably not a good idea. But, you know, I have patients like, I'm going. So you have to go through, you know, what things, because you don't know when you're going to bleed. And then understand the blame game. A lot of patients and parents are upset, and they'll say, well, if Susie hadn't pushed my child, then he wouldn't have a bleed. Your child has a bleeding disorder. We have to deal with what we have and understand, Susie, you understand that patient's parents and how frustrating it can be. And then I have a family with Glanzmans, and her mom is the bomb diggity. She is always sharing with me, you know, what she did for a nosebleed, how she used special tape to help with bruising. And she's always willing to talk to other family members and to educate me. So if you have a rare bleeding disorder, it is truly super rare. Please educate your medical team as well as other folks who may have it, because your insight may be really life-saving and make that path a lot easier. I put the resources for Super 7. Your HTC, we just had a great lecture on that. There are a lot of resources there. There's programming with Hemophilia of North Carolina and the National Hemophilia Foundation. Always keep a complete history. Something that you may think, oh, it doesn't matter about, please be able to tell your physician because it may be important. And then programs like this, the more you educate yourself and your child, the better off you will be. This is one of my patients who has hemophilia A, but he played flag football, and his mom posts this. She's hemo mom. He's stuck with his prophy schedule. He's thriving. When we work together, we can come up a plan, even with these rare bleeding disorders, to make it livable. And our goal is for you to reach your goals at the best you can. And so last, because I didn't get to talk about platelet disorders, the Platelet Disorder Support Association is amazing. So I put that website. If you have telangiectasias, cure HHT, and then a global website is the National Organization for Rare Bleeding Disorders. That includes the whole pathway of which ones are considered rare, and they often have support groups. Last, always can come to your hemophilia, your happy hemophilia team. I didn't go through all of the clotting disorders, and I didn't do platelets or vasculature. However, your HTC will be able to help you, and maybe one time we'll be able to talk to about platelets in the future. So we've